Good morning, class. Today we are going to discuss cardiac surgery. Before we get started, can everyone please log into, get out your cell phones and text Melissa Murat 873 to 22333 in order to describe the heart in one word. After everyone is logged in, we will see responses come up on the screen. So now we're moving on to indications for cardiac surgery. Some indications for cardiac surgery are coronary artery disease, angina, regurgitation, prolapse, and aortic aneurysm. Approaches for cardiac surgery, the first one is you can go through the groin. It's angioplasty and stent placement, thoracic endovascular aneurysm repair, which is abbreviated and as a TAVR, and FEMPOP bypass. The minimally invasive approaches are a mitral valve repair and a transcutaneous aortic valve replacement repair. A sternotomy is a CABG, a heart transplant, an aortic valve replacement repair, mitral valve replacement repair. That is when they have to crack open the center of your chest to assess your heart or to get access to your heart. So another question that we will use the same login and number to join. The question is, in order to perform a heart transplant, which approach do you use? And the answer would be a sternotomy. Here's some pictures of the different access or the approaches. So the sternotomy, like I said, is crack right down the chest. We like to call that a scissor because the staples leave like a scissor implant on the center of your chest. Minimally invasive is, as you can see, is very small incisions, and the catheter goes through the groin area, whether it's on the right side or the left side, and they send a wire all the way up to the heart to place the stent. Post-op care of patient. Some precautions are, for open procedures, no heavy lifting 5 to 10 pounds, no raising both arms overhead at the same time, no putting both arms behind back at the same time, no pushing or pulling anything over 5 to 10 pounds, no driving until cleared by surgeon, splinting with cough, laughing. That means, I don't know if anyone's ever seen, but the heart pillows that you sometimes get in the hospital, patients will sometimes hold them tight to their chest when they have to cough, sneeze, just for comfort. For minimally invasive, no heavy lifting 5 to 10 pounds. Okay, so here's another question. Name 2 post-op precautions for open procedures. One will be no driving, and the other one will be no putting both arms behind your back at the same time. Indications for cardiac rehab. Within the past year, if you had a myocardial infarction or an acute coronary syndrome, status post CABG, status post PCI, which is a pre-cutaneous coronary intervention, stable angina, heart valve surgical repair or replacement, and heart or lung transplant. Phase 1 cardiac rehab. Begins in the hospital once the patient is deemed medically stable to participate. Initial assessment includes patient interview regarding lifestyle, identification of risk factors, and prior level of function. Physical examination is vital signs, range of motion strength, osculation, chest wall inspection, palpitation, skin integrity, pain, and vascular integrity, as well as functional mobility and self-care evaluation. Treatment includes educational cardiac risk factors, education of precautions with activity, which may include sternal precautions if post-op, early mobilization and progressive ambulation, stair training, home exercise program including warm-up and cool-down exercise, encourage range of motion of shoulders but done unilaterally. aerobic activity, Borg scale of perceived exertion, monitoring of barriers to exercise via vital signs, and discharge planning. Phase 1, cardiac goals, independent with all activities needed to return home or progress to an inpatient rehab setting. Independent with sternal precautions where applicable. Independent with home exercise program. Independent with the use of Borg scale or other symptom scale for self-monitoring of exertion. Borg scales for perceived exertion. So this is the scale you would use to assess the patient's exertion. And you don't want them to be in the somewhat hard area, and you definitely don't want them to be in the heavy area. So where the two circles are, that's kind of where you want them to be. Phase 2, cardiac rehab. Can begin as soon as patient is discharged from hospital and extend 8 to 12 weeks. Occurs in outpatient setting or in home care. There was a journal article that showed no different in functional measures with home care-based cardiac rehab with PT frequency of 1 time a week and use of telemedicine. And insurance covers up to 36 visits within a 12-week period. Initial assessment includes assess presence absence of JVD, a sign of acute congestive heart failure, evaluation of chest including skin integrity and any surgical incision, evaluation of circulation edema, vital sign monitoring, osculation of the heart and lungs, exercise test, 2-minute walk test or 6-minute walk test, and quality of life of disease-specific questionnaires. Treatment in phase 2. Warm-up phase, 5 to 10 minutes. Allow for adequate stretch of the muscles. Allow for vasculature to dilate. Peak interval phase is 15 to 45 minutes, depending on level of conditioning. Also, the doctor may give a specific exercise prescription, exactly what they want the patient to accomplish during the peak interval phase, and vital signs being monitored throughout. The cool down phase is 5 to 15 minutes, slowing muscles down so that blood continues to pump to the myocardium and prevent arrhythmias. Exercise prescription. Mode, aerobic superior to anaerobic at this stage. Isometrics may cause increase in myocardial demand. Strength training can be started at 6 to 8 weeks. Exercise should be performed continuously for training effect. Intensity, difficult to determine. There is some evidence to suggest that strength training is beneficial. High intensity per minute for clinically stable in the heart failure population. Progression, increased duration, frequency, and intensity. Determining exercise intensity, heart rate response may be blunted due to meds or pacemakers. 70 to 85% of maximal heart rate. They give you this formula to figure out what the maximal heart rate is for yourself. The RPE scale, the VO2 max, 40 to 60% for patients with heart disease, MET level, and always monitor symptoms. Abnormal responses to exercise, dizziness, lightheadedness, syncope, short of breath, diaphoresis, desaturation, angina, ST depression, or elevation. Now we're going to use the same questionnaire. Name one abnormal response to exercise. So one might be a diaphoresis. Phase 2 goals. Modification of lifestyle, decrease fear and anxiety over CVD, improve functional capacity and endurance, return to community activities and vocation, promotion of self-efficacy. This is just a guideline of for home care that we use for cardiac patients that discusses, as you can see in the purple circle, discusses sternal precautions. So as we mentioned, no pushing, no pulling, no both arms overhead, heavy lifting more than 10 pounds. Like I mentioned, squeezing the pillow to cough or sneeze. It's good to walk every day, a little further each time. Do not walk in extreme temperatures. Can do activity you feel comfortable doing and pay attention to symptoms. Can go up and down stairs throughout the day, but not, only a few times. No driving for 4 to 6 weeks for sternotomy incisions and 2 to 4 weeks for groin incisions. This is also a good handout to have too for home care patients. For urgent issues, they need to know who to call, the local cardiologist or the cardiac surgery office, and the phone number is provided. Any questions or concerns?